especially with fire-based agencies in terms of uh, getting education scheduled. But I would suggest that trying to do this in ways based on your local resources. Some of it could be cognitive online, and then skill-based at the stations would be really useful in terms of your medics. So I want to stress that airway management really is a process that requires intervention and reassessment, followed by escalation as needed based on the clinical condition. You want to go with the basic life support first, and there's many instances in the ED when somebody who is in respiratory failure just needed a jaw thrust, as an example, to begin breathing. So I think this needs to be part of it. And if we think of airway management not as skill-based or intervention-based, but as a process that includes assessment, reassessment, and skills, we'll be better off. So I have put on here kind of this process. So position the head, open the airway, right? And consider airway adjuncts, adding oxygen. If needed, consider CPAP. CPAP has been our friend and helped us avoid intubation for a number of patients. Bag mask ventilation is a skill, regardless of your level, that needs to be mastered. SGA has really become much more prominent, and I'll talk about some emerging data that suggests that many EMS systems now are moving to an SGA, such as an iGel, as a preferred invasive airway. And then ETI if SGA is contraindicated or cannot ventilate. And then finally, the difficult airway mitigation. All of this is part of the education and training of EMS clinicians in the field. So some strategies that have found to increase reliability is establishing this standardized airway management protocol for really patients of all ages. I mentioned that earlier, but I tend to think that how important it is, especially in the pediatric patient, in which kind of the cognitive load is increased based on sizing the equipment and the opportunity to practice the skills on live patients, which is few and far between. And many systems see less than 8 children that require advanced life support in a month. And so that is going to be really a challenge. And so you have to be deliberate about practicing these skills. You want to recognize the type of airway management and ventilatory support and the timing of the intervention. And it may be different for respiratory failure, trauma, and cardiac arrest. And I suggest this based not only on data that's been published, but also my own experience. And then plan for a difficult airway with predetermined strategies. So when do you escalate? What do you do next? And airway obstruction was brought up, and that is really a problematic. I saw it in the chat. I mean, airway obstruction is something you really have to think about almost separately. Obviously, airway obstruction is going to be make an SGA contraindicated, so it needs to be considered, and especially in children in which you're unable to get chest rise with bag mask ventilation. Moving on, I just wanted to talk about the fact that in EMS, we are re-examining the role of intratracheal intubation versus supraglottic airway, and Jeff touched upon this. But there's been a number of trials recently, Henry Wang's group at the Rock trial, and the effect of the strategy of laryngeal tube or King airway versus endotracheal intubation showed improved outcomes at 72 hours with the supraglottic airway in adult patients with cardiac arrest. Henry and I have been planning, and Henry is the lead on the PD-PART trial, and we've initiated that trial looking at supraglottic airway versus versus bag mask ventilation in 10 EMS communities and 65 agencies across the United States. So in the next few years, we're hoping to get additional data relative to the use of supraglottic airways, specifically the iGel, in the pediatric patient. The Airways 2 trial showed no difference between the supraglottic airway and tracheal intubation. And then the CAM trial really showed that BVM was equivalent, basically non-inferior, and to the advanced airway. So honestly, their sample size and their metric was probably off, so it's fairly inconclusive, but they couldn't show a difference between BVM and ET in the adult population in cardiac arrest. I wouldn't be a good pediatric emergency physician if I didn't say something about children again. And airway management is obviously not a one-size-fits-all. And so you need to have strategies that help decrease the cognitive load. And I think others are going to talk about this later. But checklists, use of a link-based resuscitation tape to help with weight estimation, especially for children who are critically ill or injured. We actually developed a free app in Los Angeles to address this issue. When I became medical director, I said, we're not going to calculate any drugs. We're not going to determine the sizing. So we have everything in a free app on LA drug doses. And again, it's based on a formulation. So I think the key thing is it's not a one-size-fits-all. You have to develop strategies and tools for your medics. We heard in a qualitative interview of our medics, we heard that they wanted at scene, just-in-time resources to better care for children. The other thing is practice with the EMS, both BLS and ALS providers together. The team should all know the drill. We do know that implementation of pit crew is a great way to determine who's doing what and to really define your team and roles ahead of time. The other thing is pre-arrival strategies, such as you're going on scene, who's doing what, and going over that prior to arrival on the scene. So some of the other things to consider is practicing these techniques. I brought it up previously, but I can't emphasize it enough that, we've all heard the adage, practice makes perfect, and it's really true. The more you practice things, the more you get that basically muscle memory and that psychomotor memory that helps you perform the skill more efficiently. I hear him talking about pre-arrival reviews, so knowledge is power. You can do that. Also, providing as a medical leader within your system to provide some of these tools for your medics, either online or on an app, to be able to really review what they need to do, and also just in time. Before I left as medical director, we were filming just-in-time videos for rarely performed procedures. So I'm hopeful that that will be up, and that will certainly have access to anybody in the country. So very excited about that, and getting basically some monies to be able to do this just-in-time review for our medics. And then the practice of team play, and also just the skill practice, both for adult and pediatric. And I would suggest practicing back mask ventilation as well as invasive airway, including supraglottic endotracheal intubation, and then airway obstruction. All right, this was just published, Henry Wang and colleagues looking at 47 million ESO records in terms of advanced airway management or invasive airway management. And what they found is interesting, but it's really a trend that we see in EMS, is that the number of ET attempts have gone down pretty significantly from 87% of the time to around 55%. And SGA going up from 25% to 61% of airway attempts. And no longer is SGA considered a rescue airway. It can be a rescue airway, of course, and this was mentioned. I think it is important to maintain all the skills, but just understanding that there may be different strategies in terms of use of endotracheal intubation going forward. It is important to understand that ET can be a morbid procedure, and certainly hypoxia is one of the biggest risks, as well as aspiration, malplacement of the tube. So some data has shown that greater than 2 attempts is associated with overall 4 times the risk of adverse events. And that's certainly been true. I always say, optimize your first attempt. Just don't rush into the procedure. You want to position the head, open the airway, get yourself set, have a partner that's helping assist you with jaw thrust and handing you the tube, etc. So you want to optimize that first attempt or restrict the attempt to only one, because you're always best on the first attempt, and your self-efficacy and your whole confidence level goes down after a failed first attempt. So I would consider using an SGA at that point. So bailout points, this is important to understand too, right? We've all experienced where somebody is clearly not getting it, but says, no, I'm going to try one more time. I just want to try one more time. Don't be too vested in your own success there. And so the team members you got to empower your team to support stopping the attempt. It shouldn't be over 60 seconds. Bailout could be drop in pulse ox or bradycardia, and then generally you would go to bag mask ventilation, either 1 or 2 hand, depending adults or children, or the ease of being able to get good mask seal. So all of these are important. So these bailout attempts, if it's accepted that these are appropriate bailout attempts, then the attempt will be stopped appropriately. And I think that's really the key, is that you all agree ahead of time. And I think that really makes a difference. Moving on to credentialing and training, these are all very important, and a system for credentialing skills, so mastery of skills. Regular hands-on training, I've said over and over again, but I think it's important to understand that. And periodically review what's out there in terms of position statements and guidelines, as demonstrated on the slide, I think is really, really helpful in terms of looking at your own protocols and improving them based on evidence, or certainly some of this is consensus opinion, because we do not have the evidence for everything that we do. Oh, am I on my last slide? I think I am.
You are.
With that said, I'm available for questions. I brought up a lot of probably controversial things, but I think it's important for us to understand that really medicine is dynamic, and paramedicine is dynamic with the healthcare system, and we have to address that and continue to modify our protocols and our training to address emerging concepts. So stop there.
Thank you so much, Marianne. I appreciate it. Next up, Chief Tim Burns from Montgomery County, talking about manual reviews. Tim?
Good morning. How's my audio?
Sounds great.
All right, hold on. Let me share. All right, look good?
It does. If you just click on your, there you go. Perfect.
All right. So, all right, yeah, like Mike said, I'm Assistant Chief Tim Burns. I'm currently the Chief Training Officer for Montgomery County Fire and Rescue. But up until about May of this year, for the past several years, I've been involved in quality management as both the quality improvement officer and then supervising the whole quality management process for our EMS system. So getting into this, just a little bit of background about us. So we are right outside of Washington, D.C. in a metropolitan area, but we span the gamut from urban right down by the D.C. line to some very rural parts of the county. We're about 500 square miles, 1.1 million people, 1,400 career employees, roughly the same number of volunteers. Out of 35 stations, we've got about 45 transport units. We put 53 ALS resources on the street a day, 51 at night. We do about 104,000 EMS calls for service and about 72,000 transports. And what we're going to talk about today is about 800 or so cardiac arrest resuscitations a year. And we do not do drug-assisted intubation. So we would not be able to participate in this fully, but what I'm going to talk about is how we do case reviews of our intubations and some of the quality improvement steps that we took in that narrow scenario. But I want to share it with you because I think it's applicable to what you guys are doing and just the whole quality improvement process. And the other thing about us, we have 419 credentialed ALS providers. So we do deal with the problem of skill dilution and folks not just not doing the skill, right? We have 419 ALS credentialed ALS providers and 824 cardiac arrest resuscitations, which is where the majority of our intubations happen. And so, you think, oh, well, that's 2 per year, but that's not 2 per year. We've got one person who's doing 20 and the vast majority of people who are doing none. So a little bit of history of how we got here. In early 2020, we were using the King Vision. It was at the end of life. We knew we had to replace it. There was no mandate to use video laryngoscopy, and it had no capacity to record. And because of these things breaking and not being able to replace them, we were at a point where we had more work sites than we had VL devices, and everybody was mainly just doing direct laryngoscopy. COVID changed everything for us. I'm sure it did for everybody else. We were planning on deploying the AirTrack. I believe we already had the devices purchased, but we just needed to accelerate the timeline. We did hands-on training at the work sites for all the credentialed providers, and we also implemented something we called crisis standards of care, where we de-emphasized but mandated video laryngoscopy. So we told folks that in the setting of cardiac arrest to do it later in the resuscitation, but if you do it, then it had to be by video laryngoscopy with the new AirTrack device. The other thing that switching to the AirTrack got us was the capacity to record. So we knew that we wanted to record every intubation and then we wanted to review it. So we set up a system where at the end of the call, the provider would upload the video to a JOT form. And that allowed us to, without having to go out and physically touch every device across a 500 square mile county after every resuscitation, it came into a centralized place for review. And just in the very few first months, we learned a few things very quickly. We had a 0% first pass success rate of the videos that we were able to collect and review. There were a multitude of common errors, and what was being reported in the PCR was not accurate. So I don't know if anybody else experiences this, but if you're not looking, of course, it's one attempt, one success, right? And move on. That's the easiest way to enter it in the PCR, and it makes you look good. I'm not saying that they were purposely being deceptive. That was just our culture. So we use first pass. You can use anything, but we were historically set up with first pass, so we decided we wanted to incorporate our video reviews into our first pass review process. And what it does is it populates based off when somebody selects an intubation procedure, either video or direct laryngoscopy in the PCR. it populates into the first pass review. And what it does for us is it creates a database for the individual reviews. It gives us a place to, one place where we have all of the intubation PCRs and the data elements that we want to fill out on review, and it's all in one place. The other thing that the way we use first pass is we divide it into processes. So we have a process for cardiac arrest resuscitation. We have, in general, we have one for intubation. We have one for crashing acute pulmonary edema. We have all these different processes set up, and then we assign a process owner. And that way we get consistency among the review, the subjective parts of the review. We have at least one person who's making the same decisions consistently. So the way we pick our process owners, they're a field level clinician. In this case, he's somebody out there working in the street. He's doing intubations regularly. He's taken it upon himself to be a subject matter expert on all things airway, including intubation. And like I said, it gives us that single independent reviewer, and with the purpose of controlling the subjectivity of what he's doing as much as possible. So the way it works, the process, the clinician performs the intubation, they enter the procedure in the ePCR, and they upload the video. The process owner then becomes aware either through a first watch alert or just opening up their first pass queue, and they become aware that they need to do the intubation. So that person, the process owner, gets the first pass record, which has the PCR. They also go to the repository where the videos are stored. They grab the right one. They get all the stuff together, and they do their review. They watch the video and they do the review. So the questions we're looking for about the quality of the intubation attempt, some of it comes, we still pull the data that's entered in the PCR as part of the medical record. So was there a fallback to direct laryngoscopy from video? Was it a first pass clinician reported first pass success? What was their, were they overall successful about intubating the patient, whether or not it was first pass? Did they use a supraglottic airway? And is there a record in the PCR that they monitored end-tidal CO2 after the procedure? So that's just is the number there after the intubation was time-stamped. And then the reviewer tests based on the video, did they suction enough? Did they place the blade tip in the vallecula? Did they get a suitable view of the glottic opening? Was their technique appropriate? Did they advance the bougie prior to the endotracheal tube? Was it a successful intubation? Was it advanced to the proper depth? And was it a first pass success? Those are all manual questions that the reviewer answers based on watching the video. And what that gives us is information, right? What is our real first pass success? And then where in the process are we falling down? That process was developed through local expert consensus based on the equipment that we were using, right? That, that, like I said, was the tip of the blade in the vallecula? Did they advance the bougie? So we sat down with the medical director and said, how how should we be doing this? Developed a standard procedure where, there's a bunch of different ways, a bunch of different subtleties and techniques that are all valid. We said, how do we want to do this here, given the average patient? And then we use the first pass data to guide the overall system improvements. So we're not looking for the person who has a difficult intubation or who makes a mistake and then going and finding them and telling them that you did it wrong and whatever. What we're doing is looking for common mistakes, common errors, any ways we could improve the process, any knowledge deficits that seem to span the entire workforce or suggest that it's a bigger problem than this one person. So that's how we approached it mainly in the beginning, big wide net, trying to find what's going wrong, why do we have a 0 first pass success rate? we did work with Dr. Wang and published presented an abstract at the Resuscitation Science Symposium a couple of years ago, where we looked at the concurrence between what was reported in the PCR and then what was found on the video review to see if those matched up. And what we did find is that where we would have expected that the PCR, what they're entering in the PCR, would be nearly complete agreement, 16.4% of the cases resulted in a disagreement between what they said happened in terms of first pass success and what actually happened based on the video review. And that paramedics incorrectly reported first pass success in 1.6 or 1 of 6 of our endotracheal intubations. Independent review is essential in the assessment of pre-hospital ETI performance. That was our conclusion based on that work. So a little bit about our improvement process over time. Like I said, our first 3 months, we had 0% first pass success of the reviewable cases. There are a few things that go into, when a case is not reviewable. Either they accidentally shut the recording off when they were assembling the equipment, or the recording timed out before they actually did the intubation, or, the file was lost. A bunch of things happened. So these are the cases where we were actually able to get the file, and then the view of the video lent itself to review by the process owner. Sometimes you just don't get a good view, or there's a bunch of gunk on the camera and you can't see what they did. So of the reviewable cases, 3 months of 0, and that led us to panic. So we, put our heads together and said, all right, well, we were in hurry up mode to get these things rolled out. It was in the middle of the pandemic. We did do individual sessions with all the credentialed paramedics, but maybe that didn't go well. Maybe we didn't teach them what they needed to do. So let's go out, let's do some coaching, just some widespread coaching, talk to everybody and say, look, we really need you to do it this way. Don't forget about this. And then we ended up doing just retraining of everybody and put forth a new training package and ran everybody through it again. A few months in, we also started the first pass reviews. And like I said, we saw 1 month come up, but nothing statistically significant. We were basically hovering just below the 50% after we started, after the retraining and the coaching. So we said, all right, let's deploy a checklist, because they're not following the steps that we want them to follow. So we came up with this checklist, and we made it into a sticker. And in order to get to the AirTrack blade, it's on the outside of every AirTrack blade. So we give thousands of stickers to our logistics department, say put one on every blade. So they have to go through this checklist in order to do the procedure. And we found that, the only time that we've ever gotten these checklists to work is when we put it in the hands of the people who are supposed to be using it when we want them to use it. If it's for us, if it's in an app or in a bag someplace else, it's very hard to get them to even go and get the checklist. But if they have no other choice than to look at the thing while they're getting out their equipment, we find that they're much more likely to use it. So we pushed out this checklist, and we didn't get nearly the result that we wanted. We were a little bit more consistently towards the 50% mark, but then went back down, and nothing statistically significant. So we went back to the drawing board. As we're going through this, we also had some serious discussions among the leadership about pausing intubations, going to supraglottic airways only. We knew that would not be a popular decision, but for the benefit of the patient, we seriously considered it, because how can we deploy this very critical skill and know that our folks can only do it 50% of the time with any great reliability? The next thing that came along were video reviews that we share with the individual providers. I'll talk about how that works in a little bit.
And Tim, if you could pick up the pace just a little bit, we're a bit
Yep.
behind.
Okay. We started to do targeted one-on-one remediations based on the video review. So getting down to the video reviews, after each intubation, the clinician performing the intubation gets a non-downloadable link to the annotated video with tips on what to improve. So they'll watch their video of their intubation with some pointers on what they did right, what they did wrong. The process owner puts all that together, sends it out to them, gives them a little bit of one-on-one training that we can do quickly and remotely. And then the final thing that we did was the clinical practice guideline, which is a sort of it overlays the protocol and sort of lays out exactly how, in addition to the Maryland Medical Protocol, how we want you to do things here in our organization, our way of doing it. So said that you must make an advanced airway attempt in cardiac arrest, whether intubation or supraglottic airway, but it limits it to one attempt, and that you must use the checklist. It de-emphasizes an out of hospital cardiac arrest unless thought to be hypoxic, so it pushes it farther down the resuscitation. You have to do it, but not right away. And limiting it to one attempt was the game changer, because folks really took it seriously that the one attempt had to be their best attempt. And that's when we started to see improvement. And that's when we got up into the low to mid 80s. And that's where we saw some statistically significant improvement for us. Where do we go from here? We're happy with the progress. We're not ecstatic. We'd like to see improved use of the checklist, sticking to the process, and then we need to zero in on the steps of the process where we're falling down. And those video reviews help us to do that, because we've got really good solid data of what people are and aren't doing from our process. And that's it. That's my contact info. I'm happy to answer any questions.
Thank you so much, Tim. I really appreciate your thoughtful contributions and your inclusion of statistical process control charts on all your slides, which is kind of like improvement geek porn. It's wonderful. Next up, Wade Diamond, if you talk about preparing the patient.
Okay, you get audio check there.
You sound great.
Okay, great. So I'll just briefly introduce who I am and kind of how I ended up here, and then I think part of the gist of what you're looking for us from us at Orange was a little bit about our experience. Everything I'm hearing today is very reflective of places we've been, and I guess in some cases still are. But I would just introduce myself as I'm a critical care flight paramedic with Orange. I operate primarily out of the rotor operation in Toronto, Ontario, and also work on the special operations team, which is responsible for special pathogens transport, ECLS, and IABP, or more complex bariatric patient transports, as well as MCI and USAR. So we're involved in quite a few different things here, and our airway component is really finding its way to some stability, and also so that we can expand it into a variety of different aspects of our expanded scopes of practice and fields of endeavor. I would just jumping a little bit into this, I'm going to go and grab my slideshow that'll help bring me along here. I'm going to share my screen and see here. Okay. And then Jason, if you could just give me a heads up that you've got my slide up there.
You actually need to swap your display because we're seeing your presenter view.
Okay. Swap my display.
Should be up at the top there. It should say
display settings, swap presenter. Okay, now that should be the one then. How's that look?
Perfect.
I'm used to using Teams here, and I'll switch back to Zoom. My goodness. All right. So let's get into this a little bit here. I've introduced myself already, and I know we've got a bit of a timeline, so I'll try and move this along. So just a little bit about our sort of.
We're okay on, we're back on track time-wise. We're good.
Thanks, Mike. Right, that's great. So our journey here, and just a little bit about our service. So our system is a nonprofit, government-funded service that operates in Ontario. And Ontario is, as we always like to compare it, 1.5 times the size of Texas. I know my Texas friends on here will appreciate that, or maybe not. We have a population of about 15 million. We have a lot of remote areas. We service these with fixed wing, rotor wing operations, as well as ground critical care transport units. We are a fully paramedic operated system. There are all the paramedics in the system are advanced care or critical care paramedics. And they are all certified in rapid sequence intubation, front of the neck access, and supraglottic airways that you guys are all talking about today. So our process really started with, and the way that I got involved in this was in bag design, designing our flow of equipment and looking at how it wasn't really servicing our needs. It wasn't optimizing our workflow. And so with that, we started looking, and I started consulting with other experienced teams and different research groups. The first one, which I know that I've connected with you as well, is in Scotland. We spoke to them and got a lot of their ideas about cognitive offloading and how important that was. And we started to expand this idea of not just changing our equipment and how we carried it, but it dovetailed perfectly with the cognitive offloading piece that needed to happen to successfully increase our first pass success rates. So looking at the inefficiency of our equipment and design, we went and rejigged that. I'll show you some of the photos here of how we did it. There's lots of pieces on the market. We happened to decide that we needed to design something specifically that would work in all 3 of our different environments, different vehicle types. And then, of course, the Dash 1A comes right into this. So we started working towards improving our resuscitation attempts before intubation. So with our teams, they'll have options of a wide variety of vasopressors that might not be available to everybody in the group and in the audience here today. But our teams have a wide variety of vasopressors that they can use, from push-dose epinephrine, phenylephrine, levofed, etc. And as well, they have hypertonic solutions, and also we carry packed red blood cells at this point in time. So we worked really hard on establishing really strong approach to resuscitation before intubation. This seems to have worked pretty well in regards to our success. However, I might say, and I know that all of our patients are sick, that's why they're getting intubated, but we certainly do see an extremely high acuity of a very hemodynamically unstable patients, in some cases very complex, or multi-system trauma are probably some of the more common ones that we intubate. So we definitely have a big resuscitation factor before intubation. And I'm certainly not suggesting that's not the case for a lot of the intubations that everyone's doing, but it is quite high. The checklist, which I've heard you guys all refer to, has been just an absolutely put our people on point with following a standardized method. And we'll talk a little bit about culture just in a second here, but that checklist initially tends to get a little bit dismissed. It takes time to build it in, to have people appreciate that. I think from a human factors perspective, very, very strong type A personalities, which we have a few, definitely tend to have the viewpoint of, well, I've been doing it for so long, I should know how to do this, and why do I need this, right? So that's definitely a roadblock that comes up quite significantly, and I'm sure you're all experiencing that at different times. Our fundamental skills that we wanted to build. We worked on these in the lab, and we continue to do so as much as possible. I heard a couple of discussions earlier, one of your presenters that was talking about doing base level skills labs. That's what we do as well. We have on site at each one of our bases, we have a clinical practice lead. The clinical practice lead runs monthly, everyone goes through monthly training on shift. As in addition to their quarterly training as well. Airway is built into that extensively. So it is a regular thing that people are doing. And that was a big undertaking to get that, build that into our system, but it's worked very, very well. The standardize. I mean, we just, in everything, everything's so standardized now that any of our medics can go into any vehicle, and I routinely go to other bases around the province and work in the airplanes that I don't normally work with people who I've never worked with before, but everything is the same. And so when we get into an airway, we all know what we're doing, and it's really quite amazing to see that happen because it really does improve things, and that is a reality of our workplace. That we are often put in the situation where we make it work in vehicles and locations and austere environments that we're certainly not used to. And that's such a familiar situation with EMS in general. So when everyone is doing it the same way and everybody knows the expectations, you see a really, really improved outcome, a lot lower stress too. I mentioned a little bit earlier about the panic, and that stress level seems to go down significantly with all these tools. We work to optimize the workflow, and that continues with our bag development. Every time we do a new iteration of our bags, we look to optimize that just a little bit more based on our experience. We have a one-way all the time with standard 30-second drill. Everybody knows what they are. There's a verbalization before the intubation is attempted. And as all of this comes together, the culture's just slowly shifted. I think I've described quite a few of the ways in which that happens, but anecdotally, to see really, really senior people, of which I am one, but however, I bought into this from the beginning. So to get other really senior experienced people to shift their attitudes, it takes time. But as you build it into the new people that are coming in, we start to see is that it just becomes the culture, and people do start to very quietly accept that this is working, and now there's nothing to push back against. And I can't say enough about how much the human factors play into this, and I've heard you guys say it many times through our discussion here, through the discussions today. The culture's embedded, and then I've already mentioned about having simulation or training at the base level. And then also recording, which I've heard mentioned a little bit here as well. That's getting better. It certainly takes a little bit. It's on the checklist. It inadvertently sometimes gets turned off. The idea or the notion that people are worried about the review of their process, that was a hurdle to get over as well. But I would say it seems to be shifting. That's purely anecdotal. I'd have to see if what our stats are on how many we're gathering on of those videos, but that is part of the review process as well. And unfortunately, Dr. Sam Mal, who's one of our reviewers, he's doing medical online consult for us today, so he wasn't able to jump on, but I know he does a follow-up with every single every medic for every intubation. And that is how we're doing that. Thought I'd show you some of the photos. This is some training we did last year with our EMS fellow, or a couple of years ago actually, where we started to utilize, we were trying to do real world sims, increasing and elevating the simulation as much as possible. In this particular case, hot environment and hot, muggy environment outside, beside the vehicle running noise, etc. And then we're using all of our tools in the standardized approach, as well as players who are not familiar with the equipment, which is another familiar situation that I've found with the standardized approach. It gives you a little bit more cognitive, it offloads you cognitively enough that you can actually interact with your other providers and support people, whether they be first responders from fire services, or whether we're in a primary response or secondary response role into a hospital or nursing center, which we do quite a bit as well. So in these particular cases, all of this cognitive offload, and I mentioned heard one or two mentions of this earlier, the idea of workflow and the process, right? And so if you look at how our equipment is laid out with this, this is called our ARC kit, our Airway Ready kit. If you, and I can absolutely share more of these with you. You don't have to buy the ones that we designed, but it gives you an idea. It's a color-based system. It goes from a stepwise fashion. When you open it, it's like a book. So it starts on page 1, whereas your pre-oxygenation pieces, which is your non-rebreather, your nasal cannula. We also do have, we use the Hamilton T1 ventilator. So we're leaning also towards using BiPAP or the non-invasive ST mode as well for pre-oxygenation in some patients. That may not always be an option everybody has, but in any event, these are your standard pieces here. Also here is Ducanto suction, large bore suction, so that no matter what suction you have to hook up to in your environment or whatever team you might be meeting up with, you have those so you can do a full salad technique and you're not missing any equipment. It moves over to the other pages where you finally get to your intubation and your front and neck access at the back of the book. And your video laryngoscope device. I think I'm just going to go here to this. This is the published documentation that shows a little bit of our, it shows how we've been doing. That's, as I say, that's published. There is further data that's only up to 2021. Not really that surprising. We did see a little bit of a pullback on that on the -1A success after this interventional period. And the interventional period being all of the preparation of the new equipment, the training, instilling the -1A principles to everyone. So I don't have and unfortunately Sam's not able to be here today, but if we could certainly provide data on the ongoing data. But most recently we had a little bit of a pullback on our first pass success rate. We're trying to kind of figure out what's up with that, but the -1A was improving as well. However, in all these cases, we increase our training and we increase it more, and we push more intense simulation as well. So the last several simulations, we've been adding complex scenario extrication, difficult access, and decision-making with those kind of things. Now I've got just one more thing to finish up here, and I'm just hopefully this video works. This is part of our special operations deployment, and so the reason why I share this with you is so this is taking it a little bit of a step further into the world of special pathogens. And what we've been able to do is take our approach, our equipment, and everything that we've been using, and apply it into the special pathogens world, and right up to the point of we actually have used a negative containment vessel called the Epi Shuttle, and we've actually been able to sim this out of performing airway intervention inside the shuttle. So I guess what this says, I think what this says to the whole thing is that once you start getting more stable, once you start getting these the fundamentals in place and they're strong, then you can start to push it just a little bit further and start to add new complexities and still find that your success is still going to be quite good. I will just hopefully this video plays there. And I have no idea if the audio comes through or not.
The audio is not coming through.
Okay, so this is couple of my colleagues here, and they're just going through, and they are using our standardized approach, which will be a CMAC bougie tube over the bougie approach. And this is in a complex patient with, in this particular case, a viral hemorrhagic fever and septic shock, rapidly desaturating. Starts off bad and keeps getting more challenging. However, they've been able to do that. That's I just thought I'd throw the video in a little bit, and you could see the little bit of the setup here. I think I showed a couple of photos as well. Oops. Okay. And that is my part that I wanted to share with you. I hope that I've met the requirements that you had, Jason. But I would certainly, I can be available for some questions if you like.
I don't see any specific questions for you in the chat. If you jump in there, you may find something to contribute to, without a doubt.
I definitely think, Mike, there is one, it's more of a begging and pleading. I noticed quite a few of us were rather taken with your Airway bags, and we would love to get like pictures or schematics or something of those bags. Those look very.
Okay. Yeah. And so those, I get to take credit for these because that's essentially my design. I've had another colleague just do the last iteration of it, which is a slight design change. They're produced by a company in British Columbia, Canada, named FireTech, based to our speculations. But I will happily, I could send them over to Jason if I send those to you. Can you? Like, I'm happy to share it. Certainly not trying to sell anything for anybody, but that is where we buy them.
We can easily add that to the resource section on Simple QI, the platform for us. That'd be great.
And just a word to those, I think, and then in addition to that, I will show you, we also have what's called an Airway drug ready kit. So for anyone who's doing drug assisted intubations, we utilize that, and it is a standard setup, standard size syringes, with a reference card as well for drug dosing, weight-based, again, cognitive offload tools, as many as we can build into the whole program. So there's that kind of, those things go together, and then the entire bag is designed in a flow, meant to be in a flow where you're going sort of mild to wild is what one of my colleagues call it. So you're whatever your first things are set up to get, if you can get them first. We call it the 10-minute bag. So especially when we're arriving on scene or into a resuscitative situation, if you can open that bag, it should get you through your first 10 minutes. And that's the concept behind it.
Perfect. Well, Dr. Jarvis, I think you are up again.
All right. Well, and as I'm clicking on slides here, I know personally I would love to see your drug bag also. That would be amazing. It sounds great. Let's see if I can get this right. Did I get it right? No.
It's up here. Click it. Yes, you're perfect.
That's good.
Yep.
Outstanding. All right, guys. So what I'm going to do is I'm going to do an abbreviated talk that Buck Gleason, our QI manager here in Fort Worth, and I have done before. And what I want to talk about is our pathway down the improvement pathway on this specific issue. And I'm going to really try to focus on how we specifically address -1A. So some historical data, the whole point of doing this intervention was to improve. This is what our historical first pass success looked like. We were around 60-ish% on first pass success. That was not acceptable to me. It's clearly a problem. I think we've gone over this really well about why it's a problem. So we structured our airway improvement around this particular measure. We've already hit the details on this. But we wanted to break that -1A down That's a composite measure, and there are three main issues. There's first pass success, the technical skill. There's peri-intubation hypoxia, peri-intubation hypotension. So we wanted to break it down and identify where how we were performing with each of the components. So adequate pre-oxygenation, clearly we were not doing as well as we should. Looking at, sorry about that, here we go. We're looking now at first pass success without hypoxia. Not well at all. And then if you add in hypotension, still not doing well. And this is based on our manual review. I mentioned if you look at the automated reports, you'll see that you're probably, if you're anything like us, 10 to 20% higher than your manual review. So make sure you're doing I think for this, you really probably ought to be doing a manual review. And it turns out logistically, that's easier too. So the aim statement for our improvement was we wanted to improve -1A or Airway 01 to 50% within 6 months. Like all good improvement efforts, Buck led our team through a process of coming up with a driver diagram. And these were our primary and secondary drivers. We broke these primary drivers out much like we looked at those charts. And then we came up with some specific secondary drivers that we were hoping would impact each one of these key components. You can see what those are there. And then we had some change ideas. And the key part of the change idea was a new protocol, as well as a checklist and then training. Now, the one thing I want to tell you about is where we were starting. We were starting with a system that used exclusively video laryngoscopy. We were using the UE scope with their pseudo hybrid blade and a bougie and ketamine. So there were no paralytics. It was a ketamine only scenario. So that baseline data was based on VL plus ketamine only. So the protocol that we used is adapted from one that we built at Williamson County. We published the results of that in this paper. And basically the protocol, the gist of it, is that this was a mandatory protocol for all non-cardiac arrest intubations. It involved appropriate patient positioning, that's head of the bed elevated. The patient was in an intersternal notch position. We would use pre-oxygenation with non-invasive ventilation. And the way we initially did that was BVM with a good two-handed seal, lifting the mandible into the mask, not pushing down, at least nasopharyngeal airways, PEEP of at least 5, flush rate oxygen going through the BVM and the nasal cannula. They now Wilco has switched over to BiPAP through their ventilator to do this pre-oxygenation. I think the key component of it, just like the pre-oxy trial just told us, is that it's non-invasive ventilation as opposed to a non-rebreather mask. We use DSI, so ketamine to sedate the patient and allow you to do all of these things that the patient may not find particularly pleasant. Then once you have hit certain goals, then you can push the paralytic. And I think the key component of this is this goal-directed saturation requirements. Basically, this protocol said you will not push the rocuronium until you have had at least 3 continuous minutes of pulse oximetry at or above 94%, which in the absence of end-tidal oxygen is the best measure we have of adequate pre-oxygenation. So bottom line on this is it worked. Our aim for that study was decreasing peri-intubation hypoxia, and we dropped it from around 44% to 4%. I saw a question in the chat earlier about, there was a question about traumatic intubations, and there was a question about scene time, and a question about whether the duration of intubation increases if you limit it to 2 intubation attempts. We were limiting it to 2 here, and what you'll see is on trauma, just the percent of trauma. There was a slight decrease in the percent of trauma intubations from 21 down to 15%, and that was not part of the protocol. We just also stressed the importance of avoiding intubation hypoxia and hypotension in TBI patients, as well as balancing that with the need to get to the hospital. So it just naturally came down. Scene time for this did go up, a median difference of 9 minutes. And the attempt duration, interestingly, there was no significant difference, but if you look at it, it dropped from 2 minutes before to 1 minute after. And the way we were measuring that is we would have the medics push a start button and an end button on the monitor. And we're using a third person to watch the monitor at all times and do the button pushing. All right, visually, this is what we're seeing. The peri-intubation hypoxia dropped substantially. So that's the basis of the protocol that we implemented here in Fort Worth. And we essentially took the identical protocol and added in a goal-directed blood pressure requirement. Now, that's something Wilco has also done, but it was after we published that paper. So here is what the protocol looks like. That is a screenshot of the protocol on the left, and the key components, I think, are on the right. Our basic providers start off with mask ventilation, and something that is really important for us is we know these patients are hemodynamically vulnerable, and you're going to see pretty dynamic changes in your blood pressure. So we wanted to recognize trends downward in blood pressure very rapidly. So we switched to 2-minute blood pressures. This also, by the way, helps the chart get those SpO2 values because the blood pressure is the key to pulling over importing or exporting, depending on your perspective, the blood pressure readings. Our basics can start with what Dr. Miller here in Fort Worth has coined max BVM, and that is the approach to ventilation and oxygenation that we talked about before. Positioning, BVM, two-handed seal, nasopharyngeal airways, and PEEP, as well as apneic oxygenation. We then make sure we have push-dose epi and Levophed as an infusion ready if needed. We give the ketamine, then turn the oxygen through the nasal cannula all the way up, assure the correct positioning, and then we have those two goals. 94% saturation for more than 3 minutes before you push the rocuronium. If at any time in that period the sat drops below 94, you have to correct the problem, get the sat up again, and then we have little stopwatches in our kits. They have to start the timer over again because I want 3 minutes of continuous saturation. And the reason we're doing that, we are erring on the side of patient safety. So that's the reason we did that. And then we set a systolic blood pressure at 100 at the time you push the paralytic. The dose of rock we're using is 1.5. Once the rock goes in, we then set a 90-second timer. And something I want to point out about this is that we recognize that a substantial portion of patients who get rock will stop breathing or certainly have depressed respiratory effort well before 90 seconds. The 90 seconds is there aimed at making sure we have maximal patient preparation and maximal relaxation. So we are already in a position where the head of the bed is elevated. They have nasal pharyngeal and oral pharyngeal airways in if they tolerate that. We have a good two-handed seal. We're just not squeezing the bag. We're using that for non-invasive ventilation. At some point, the respiratory effort will start to diminish. We recognize that by all the normal ways, but also focusing on end-tidal CO2. And as soon as the patient needs assistance, we'll go ahead and start assisting. And as we're getting closer to 90, almost all patients will be completely apneic, and then we will have to ventilate. But we definitely go ahead and do that ventilation. After that, we also have built-in hard bailout points. If the SAT drops below 94 at any point, we bail out and then fix the problem again, resetting the watch. Same thing with blood pressure. If the blood pressure drops, do something to fix it. You've already have the push dose epi there. If you need to use Levophed, go for it, but you cannot progress until you fix those problems. Although it's not a part of this protocol, I do want to point out we have another one that stresses the importance of post-invasive airway analgesia and sedation. We also created a checklist, and this is the checklist. And then I will show you a little kit that we made in a second here. Unfortunately, I don't have a screenshot of it, so I'll just show you the kit. But this is the checklist we used, and this checklist is mandatory. We stress over and over again that they have to use this. I would really love to say that they do 100% of the time, but we're doing everything we can to make sure that they do this. You'll note that red box down there. It says if goals are not met, do not proceed with intubation. We have, to steal a term from Darren Browdy, our process for placing supraglottic airways, we call rapid sequence intubation, or rapid sequence airway, I'm sorry. And that allows you to use the drugs that you need to use to place a supraglottic if you need to. So that's what the RSA is there. All right, so that was the implementation effort. Key thing is, what did we experience as we were going through this? We started off taking a small group of clinicians, we ran them through the training, and then we fine-tuned our training. Our training consists of a series of videos on each component of this, including the rationale, the scientific rationale for why we were doing it, and the science behind each component of this protocol. This is very much an evidence-based protocol, and I wanted all of our clinicians to understand that. So we made those videos, and then we tweaked them and added additional videos as we needed based on the experience of that small group that we were teaching. I saw a question in the chat earlier about essentially how do you get buy-in? And the way we do it is by explaining the rationale for the process. There is obviously going to be some angst among paramedics. I mean, I'm still a paramedic. I understand the angst about you're trying to take something away from me. We really tried hard to stress that this is not about taking a procedure away. It's about doing the right thing for the patient. And we stress over and over again that the whole reason we're doing this is for the patient, not for our egos. And if we're going to continue to intubate, we have to do it right. And doing it right sometimes is a little inconvenient for us, but that's okay because we're doing it for the patient, not for us, not for our convenience. And then I finally stressed that we're either going to do it right or we're not going to do it. Honestly, I think the explanation of the rationale so that our clinicians understand why doing this is in our patient's best interest really got a lot of buy-in. Then we, with that small group, rolled it out and they started using this protocol in the field. And one of the things that we noticed coming from ketamine only intubations to DSI is that we were giving huge doses of ketamine, and then the paralytic. And as we talked to people and tried to dig down into why we were doing this, we found what I call a ketaminophilia. Essentially, our ketamine only intubation experience had, I think, trained our clinicians that ketamine didn't do a very good job of muscle relaxation. Well, no joke, that's not the kind of drug it is. But because the only tool we had given them was ketamine, the only choice they felt like they really had to optimize intubation was giving more ketamine. So we had to go through the concept of, you're going to have a paralytic, and I promise you the paralytic will paralyze them. So this will not be an issue anymore. We obviously got a lot of clinician feedback, and that helped drive our subsequent PDSA cycles. So I want to end just real quick talking about what our experience is. This is our pre-oxygenation. And this probably isn't surprising because you don't progress with the process without adequate pre-oxygenation. We implemented the new process in January, and you can see we've been at 100% since then. I actually forgot that I had not updated these slides since May. So I went ahead and just dropped in August right in here. So you see where we are with August. So that's adequate pre-oxygenation. This is our intubation first pass success. We were around 60. We've since moved that up to somewhere around 80. Performance over last month, 2 months ago, 90, then 91, now 89. So we're definitely seeing an improved first pass success. So that's important procedurally, but only because of the physiology. And we are seeing a clear improvement in first pass success without hypoxia. And we're seeing a clear improvement in first pass success without hypoxia or hypotension. So you can see where we started. We're now at the 50 range. We hit 69% last month. Obviously, we were 62 the month before that. I would love to say that that one data point is going to stay that way or go higher. My guess is we will see it drop a little bit, but I am rather proud of the work the team has done, and I think we're seeing some good results. Last thing I want to hit on is a little bit about data reporting and the way we abstract the data. So Buck Gleason, as I mentioned, is our QI manager. We report all of the NIMSQA measures plus a few other ones to our board every month, and they really wanted to see. They wanted a couple of things in a visualization, and Buck came up with this using Power BI and Tableau as a way of showing what our monthly performance is, what a comparator is, and then what our trailing 12-month performance is. Buck still twitches at this because he desperately wants a run chart, but at the request of our board, they didn't really want to see a run chart, so we had to accept that. I think Buck came up with a great compromise. He wasn't able to get the P chart in there, but he's got a little bit in. So that's the way we report it. Now, I mentioned Kirby before. Kirby is one of our staff folks who goes in and she looks at every intubation and every cardiac arrest. We use the Zoll monitor, and this is code review. She will take this abstracted data out, and she basically plots these charts of vital signs against time. Then she comes in, and you can see the sort of shaded area there. She puts that in. She does this part in PowerPoint. She'll take a screenshot of the plot in the Zoll code review. She plops it down in PowerPoint so she can annotate it. And you'll see the times that she puts in here along with this gray area. The gray area represents the -1A times. And this is based on the prior NIMSQA definition of 5 minutes before, 5 minutes after. Obviously, now that we've revised that, we're going to adjust this a little bit. The beauty of this is that you can look at this and say, within the peri-intubation period, number one, was it a first pass success? Well, there's only one ETI attempt. And if you look down at the purple lines with a C in the middle of it, you can see that we have waveform CO2. Now, independently, she is looking at the CO2 waveforms and annotating information in our database that, yes, this was a independently confirmed first pass success. You can look at the light blue SpO2 there, and you'll notice that within that period, there's nothing below 90. And then if you look at the green line, which represents systolic blood pressure, you'll notice that there is nothing below 90 within the -1A time period. So this represents a first pass success without hypoxia or hypotension. Blair, who also works in our office, she sends this information out to the crews after every intubation. I can pull it up and look immediately at this and see very, very rapidly, get a really good idea of what's going on with the patient. So next, we want to say, well, what's the next step in this process? We want to see why we had fallouts. The biggest reason, just if we didn't quite do the full-on Pareto chart, but you kind of get the idea here. 30% of our failures were due to first pass success misses. 26% were from post-intubation hypotension. We had some post-intubation hypoxia. And then you can see where the pre-hypoxia is from the 2 minutes before we started our timer. So we're complying with our protocol, but our protocol was built around 3 minutes before intubation, not 5. So that 4% represents that period of time. Same thing with pre-hypotension. Now, going back to the VL file, I mentioned we use the EQuIP. The EQuIP has just come out with some new software. My colleague, Dr. Miller here, has been working with this quite a bit and customizing it. He sent me a screenshot while we were listening to his great presentation earlier. We said, well, let's take a look here. This is just a quick screenshot of that new software. If you have any questions, Brian will be happy to talk to you about it. When we reviewed our VL files, this was what we found as the reasons for failure. So this gives us another opportunity to try to improve. And with that, this is how you can get a hold of me. It's how you can get a hold of Buck. And if y'all are ever, just got to plug my town here, if y'all are ever in Cowtown, make sure you go to the stockyards and say hi. So that is what I have for you.
Thank you, Jeff. I think it is time for another break. Let's come back at 5 minutes after the top of the hour, 5 minutes after the top of the hour, and we will get caught up and get out of here on time. Thank you, everybody. All right, we'll fire up here in 1 minute. All right, I think it's time to hear from our executive director, Cherie Murphy.
Thanks, Mike. I feel like we're gonna take a really sharp turn here from the clinical into some of the technical administrative pieces of the collaborative here. For those of you who don't know me, I'm Cherie Murphy. I'm the executive director for National EMS Quality Alliance, or NEMSQA. My background, I spent the good part of my career working with the American Heart Association in their healthcare quality programs, first in the acute hospital side, and then working on Mission Lifeline, which is where I developed my love and passion for EMS and helping get EMS the resources to do improvement that I felt was very heavily hospital sided. And then had the opportunity to come and work with NEMSQA as the executive director, and then decided that I needed to get some street cred and became an EMT, and I volunteer with a fire-based rescue squad here in New York. So getting us back on track with some time. I will be pretty quick, but I figured what I wanted to do today was to clear up any confusion that there may be around the communications and software platforms that you may be getting invited to join. So many of you may be receiving communications from me or from NEMSQA thinking, I didn't sign up for this. But as participants of the Airway Collaborative, all agencies or organizations are NEMSQA members, and so have access to NEMSQA member resources. And you'll not only receive communications related to the collaborative, but also just general NEMSQA communications. You are not obligated at all to participate in any of those opportunities, but of course, we hope that you will take advantage of those opportunities and get involved in some of the other NEMSQA activities. So there are two different software platforms. Mike Tagman is going to talk about Simple QI, which is the collaborative learning platform where you will enter your aggregate data, your PDSA cycles, and really do a lot of the, as we've been saying, interaction and sharing of resources around the collaborative. I'm going to really quickly, in like 5 minutes, just overview the NEMSQA membership platform, just so that if you want to be able to access and be involved in that, you can. So everyone who is part of the collaborative and has been added to the agency membership should have received, you either have access, you have a username and password because that already existed, or we transitioned it over into an agency membership, or you may have received a system generated email to reset your password. That sometimes goes to spam, so certainly check spam. But if you don't have that and want to be able to access this, please just send me an email. I know you've gotten them from me, so you know how to reach me, and we'll make sure that you can get set up with that. Once you're logged in, on the member page, there is links to different resources. Really, the key thing is if you want to get involved in other NEMSQA opportunities is to take the NEMSQA member engagement survey. Again, not required, but offered. And there you'll be able to elect the different committees and opportunities that you'd like to be involved in. You're probably getting some calendar invitations to other meetings that are not specific to the Airway Collaborative. We do have quarterly general membership meetings where we give updates on organization activities, so you can hear about everything that's going on and what you may want to be involved with, as well as our monthly member learning and networking opportunities, which are different topics. They rotate Monday, Tuesday at 11 Central, and our call this month on Tuesday is dedicated to looking at or for folks who use our statistical software in EMS data in order to do some collaborative learning about that. So this may be something that some of your team may be interested in hopping on to connect with other folks who may be doing some of this analytics, and they may be able to connect and get some support in some of the work that they're doing, hear what others are doing. Within this software, there are also, sort of similar to what Mike's going to show in Simple QI, discussion boards and other opportunities to connect with just NEMSQA members on things outside of the Airway Collaborative. And then I'm not going to go through this because I really just want to turn it over to Mike to go through Simple QI. You know, if you're frustrated with the level of communication that you're getting, or other folks on your team are, because they're connected to this project through the, you know, the application where different individuals needed to be input, those notifications and communications can be modified. So please don't feel frustrated. I hope people don't want to opt out, but if you do, like, we don't want to be annoying. So please let us know if you're having trouble figuring out how to change your settings, but you can do this within your member profile. Sorry, this is just another thing around communication settings within your member profile that you can change. So I would say key takeaway is you will receive other communications from NEMSQA just related to general NEMSQA. If you don't have access to that, shoot me an email and we'll make sure that we get you set up. I will be honest that I do all the back end administration, so I'm still trying to figure out how an agency lead can add their own agency level contacts. I don't do that front end thing, so I still have to figure that out. In the meantime, I'll make your life easy and just do it for you. If you just send me a name, email, title, I will get folks set up. So Mike, with that, I'm going to turn it over to you.
That sounds good. Thank you so much. So are you seeing my Simple QI?
Yes.
Perfect. So Simple QI is a software platform that was created specifically for large quality improvement collaboratives like this. The folks that created it were the people who built the intranet for the Institute for Healthcare Improvement some 25 years ago, and built their online collaborative learning system, and then stepped out and started this organization that is focused on large scale collaboratives. So this is the, you know, people say, how do you get 60 organizations to work together and learn together and share data and information? Well, Simple QI is the answer to how. So you all should have gotten an email to sign up for it. We can tell who has accepted their invitation and who has not. And so I went through, and everybody who was on the application list, at least, which might not be everybody on this call if your name was not on the application when you applied, but everybody whose name was on the application has gotten an invitation to join. You may need to look in your spam folder or someplace else on your computer. I resent invitations to you today, so you don't have to go searching way back for your through your old emails, but look for Simple QI today. And each of you have a team, and I went ahead and set up a test team just to walk you through it that I will delete after this. But your team gives you a number of resources and things within this. I will also let you know that there is an overall project homepage which this is the main project homepage. All of the project level resources get uploaded to the resources section here. And our big discussions and the big discussion group happen here. But I want you to orient yourself to kind of your own homepage. And if you want to go ahead and log in right now on yours and just follow along or poke around and play, you are welcome to. It is hard to break, but it is a great resource. So we have populated the AIM here, and you'll notice in the AIM we've got increased the percentage of first pass success with endotracheal tube placement without hypotension or hypoxia to blank % or greater. We've got a blank % in here because we want to get baseline data from everybody in this collaborative to find out where our baseline is starting from so that we can set a reasonable goal. And then if you this is kind of your navigation area on the left side here. If you click on people, you should see your name there in the list. And one of the things that's nice about this is this organizes the nationwide collaborative, but you can also organize all your own team's work. So you can add as many team members as you want. We can just add a team member here with an email. And it allows you to select what role. Team administrator allows people to control things. Team contributor, it gives you a different list of options. If you're not sure which one to assign, you just click on this little strategy here, and it tells you what each of the different levels are allowed to do in your system. So it makes it very easy for you to sort out and decide how you want to assign people on your team. If they're not already in SimpleQI, they will be sent an email inviting them to join. I encourage you to let them know that you've done it so they don't think it is spam. And there's no limit to the number of people that you can add to your team. All right. The second question in the model for improvement is how will we know that change is an improvement? And that has to do with our metrics. And we have got a set of measures here for each team to participate in. There will be a little bit of a difference if you're a team that does not do intubation of patients who are not in cardiac arrest. You'll have a little bit of a more limited number of measures, but they're all here for you. And if you want to understand what a measure is, you just click on it, opens it up, and and you can learn more about it. And this will allow you to input your data, and you put in. We're asking for monthly data from everybody on the team, and we would love for you to set reminders in your Outlook calendar right this minute to remind yourself to upload your data to SimpleQI every month during this collaborative. One of our challenges with the Lights and Siren Collaborative was that people would load a bunch of baseline data and then they wouldn't load anything. We wouldn't know where people were at, and the feedback is the root of excellence around this. So we need to know where everybody is. So please build yourself a plan so that you can upload your data on a regular basis. If you've got a spreadsheet with a bunch of data in it and you want to upload it, there is the ability to upload large groups of data. And if you're not sure how to do that, if you come up, there's a little question mark up here at the top, and it says get help for common tasks. And all you do is click on it, and it will open up a list of videos. And for data, it's like if you want to enter multiple data, it'll bring up a 2-minute video that shows you exactly how to do that. So it's the help resources built into this are pretty robust. A number of folks mentioned driver diagrams during the course of this, and Jason has done a wonderful job of taking the change package from our expert panel that is leading this adventure and building it into the driver diagram within SimpleQI. So you basically what you do is you imagine on the left side over here, this is the AIM, and these are the things that contribute to the AIM as far as primary drivers and secondary drivers. But the real kind of operating unit of driver diagram are the change ideas here on the right. And these are all the different things that you can do and test to be able to improve your airway management performance within your own system. And so from these change ideas, when you want to fire up a change idea, there are actually 3 different ways you can get to it. You can either click this little arrow by the change that says start a test. You can go to the tab over here that says changes, and it will list all the change ideas that you can click on any of those individually, or you can go to the PDSA tab and start a PDSA by clicking your first test of change. I find the driver diagram is the easiest place to do it from. And you click start a test, and it will open up this strategy here. And it says plan your first test. So we'll just name this first test. And you'll create it. And what it does is it opens up basically a template which gives you instructions for how to conduct a PDSA cycle. So if you are going to design a user-friendly equipment to minimize cognitive load and enhance usability, which would be basically making up a model of Wade's Airway bag would be an example of doing a test like this. And then you say the objectives are to test the Wade bag to see if it reduces cognitive load. And you can do spell correction within this. And then you come over here and you list questions and related predictions. So you decide our prediction is that the bag makes things easier. You'll be more eloquent than I just was there. And ask a question of is the bag easier than memory for remembering what size and all those kinds of things to use, right? Make that a question mark. And then you plan your details, and maybe you're going to test this in the simulation center. So we're going to use the sim center and have Stephanie and Tyrone test memory and the bag on a simulated adult in severe respiratory distress or whatever it happens to be. And then you're going to collect your data. And so the data will be feedback from these two and timing. And then you say, when are we going to do this? You come in here to your calendar and it's like, today is the 17th. We're going to do this tomorrow. And we're going to do it tomorrow afternoon. And we're just going to test it as a knowledge gathering PDSA cycle. And then you run your test. And then once you've run your test, you say, what did we observe? That the zipper got stuck. Whatever it is you observed during the course of things on the bag, whatever it is you learned here. What are your observations? Because your qualitative observations are just as important as your data. And then when you come down here and you say study and analyze the results, this is where you can copy your predictions here and then say, what did we learn? We learned that the zipper got stuck. The crew liked the bag and they were able to 18 seconds faster, whatever it is you learned. And then you decide based on your PDSA experience, Is this something we want to adapt? Do we want to abandon or adopt? And in this case, we said probably adapt it because the zipper got stuck and we want to fix the zipper on the bag. So the next steps is fix the zipper and test again. And then you record it. And so that then all of this information is recorded, and what you learned in your PDSA cycle will be available to everybody else on our team. Okay. For your individual team, you can upload resources as much as you want. It's very simple. You can add a file by dragging and dropping it here, whatever you want to add. The report section will show you what your team measures are, and we don't have anything, haven't put anything in here yet, but it will show you a run chart about your things. It allows you to export, import, do all kinds of other things here. So that's a quick overview from this perspective. The place where you want to make sure you spend your time is in your measures and doing your PDSA cycles, uploading your measures and sharing your PDSA cycles. That's the real value of a collaborative, so that we can all learn together. You can start team discussions on any topic you want. So we can start a topic on stuck zippers, or we can start a topic on, there's a lot of conversation in the chat today about, are you an ESO user, EMS charts user, image trend user? Are you a first watch user? Do you do manual review? Do you set up automatic reviews? There was a ton of things around that. So that conversation can be continued through threaded dialogue here. And you just add that, and then everybody who is on your team will get an email that will contain what you just had posted, and they can respond via email, or they can log into Simple QI and respond, and you can have threaded discussions on all kinds of topics. So for our main project area, that's where this is. And so all of you who've got suggestions on how to do things with Continuum, or whatever things that you're working on or curious about or whatever, the richness of the meeting chat for this particular webinar has been amazing. And my dream is that you will absolutely continue that using the discussions on Simple QI, so that we all get to learn and share information from each other. If you've got an article or study that you want to upload or continue, or you've got a cool wave file from a video laryngoscope that you want to be able to share the video of, you can upload it here. The only thing that we ask you to be really cautious about is do not share anything that has any patient protected information on it. This is not a HIPAA compliant website. So we want to make extra sure that you're not sharing anything that would be something that would launch the HIPAA investigation of any kind. So what questions, comments, quips, quotes about anything does anybody have on this? Tim, you've got a question?
Just real quick on the measures section, is there granular ability to make levels within your organization? So let's say we have 5 different regions, and it says, hey, upload your monthly data. Is that aggregate for all regions for us?
So you are channeling your inner Cherie, because she just sent me a file that gives you specific directions on how to do exactly that. So if you've got different divisions, if you are a region that has several organizations, and you can either pull the data or upload it separately, and Cherie will upload those directions to the resource section here on Simple QI to make it easy for you to do. Cherie, anything you want to jump in on that?
Yeah, I was just gonna say, Mike, if you go to the test site, I kind of set it up there, but yes, there's a functionality in the measures called series. where you can sort of group your data in different groupings. One of them obviously could
This is
be
over here, the
agency.
add a series.
Yes, one of those could be agency or location. And so I forgot to do it. It was one of my multitasking things I was going to do while everyone was presenting, was upload it to Simple QI. And I will do that right now and throw the link in the chat to the resource that shows you how to set that up. You
Great.
will have to do it. I just want a couple caveats. You will have to add that series to every measure.
Right.
So when you click on each of the measures that's in there, so like the adult, the pediatric, so all of the measures, you will have to add the series to that.
The last piece of it is, I think it was just asked in the chat as well, of should we wait till the changes happen and we can vet our data through, I mean, we have multiple ways to gather this. I just want to make sure that it's right.
So this is a good question. So this is the do you recommend that waiting until the vendors put the updated NEMSCO measures in to upload data? That's a great question. Jeff, are you still on? You want to weigh in on this one?
Mike, just to clarify the question, is it for the vendors to put it in, or Cherie said they're going to be posting the new measures on the site? So before we pull our data, should we get the new measures per se?
Yeah, that's a great distinction, Steve, and I was going to chime in and speak to both of those distinctions. So I think number one, I think it would probably be best to use the new criteria. I'm going to post those tonight. I got the final versions, so I will get them on the website tonight. So I think the new versions would be the better version to ask. As far as waiting for the vendors, I mean, that's sort of almost, I'll say, sort of a personal decision a little bit, because waiting for the vendors could set you back some time. But obviously, if from an efficiency standpoint, getting that baseline data would be easier having the vendor automatic pull. You certainly could wait, but I'm not certain what the timeline on the vendors automatic output is going to be. And, from the conversation today, it seems as though like maybe there's like some partial solutions in place. So I'd say it's a little bit of a personal decision. But also I think I'll channel my inner Mike in that you probably don't want to like wait 3 months to get baseline data, but I also, want to balance your workload and what's realistic.
Yeah, I mean, our
So
overall hope is
hey, Mike, this is Jeff. I'm still online. Sorry, I had
Oh,
to
thank you.
manipulate my phone. So what I would urge you to do, because we know that the reported difference in automated reporting and manual reporting is significant, I would make sure not to do one thing for your baseline data and another thing for your ongoing data, because that will report a difference that is arbitrary. It's not because of your performance or your improvement. It's just because of the way you're measuring it. So I would strongly urge you to do the same thing throughout. And because of the challenges we talked about with automated reporting of particularly Airway 01, my recommendation is that you not wait for the automated report. I would recommend that you do this on a manual basis. Now, for the respiratory O2, that's such an easy measure. Number one, I think most vendors already have it. And number two, if they don't, that's a relatively easy report to write. Just search for lowest O2 and whether they gave it. So I think that you should probably do the entire thing manually. And I really urge you not to switch measurement paths halfway through.
That is really, really important advice, Jeff. Thank you for that. Does that answer your question?
That helps a great deal. I guess what I'm wondering is, say we start with what we think is appropriate, and then we find that there's a slight tweak in the vendor's engineered version. Can we update our data based on that new tweak? Obviously, measuring the same thing throughout, or is it going to cause problems for the whole collaborative if we start putting something in and then change to that slightly different standard for the whole data set partway through?
Yeah, I think if you're going to update baseline data that you've already uploaded, I guess the request would just be to let us know. Let us know that you're doing that. Go ahead, Jeff.
Mike, I wanted to let you address that part about what to do with the data you're uploading. But just one other thing that I would recommend is when you're dealing with your vendors, you absolutely 100% have to trust but verify. And this is for two big reasons. Number one, these are new measures for them also, and they're complicated and they can get it wrong. Number two, though, and this is by far most important, is that the way you're putting your data in may not match with what the national data elements are. So you may get wildly different measurements based on how they're measuring it and how you're measuring it. So don't assume that the thing coming out of the can is accurate. And that is not a dig at any of the vendors. This is a really challenging problem, but you know best how you're collecting your data and what accurate is. So I think you should trust it, but verify it.
Yeah, it should be an iterative process until you get it dialed in where you're confident.
Absolutely. And so Mike, one other thing that I wanted to point out, I saw somebody put this in the notes. So one really good, useful tool for vendor reports is to identify cases for manual review. Obviously, Mike is very familiar with FirstPass because the entire thing is built on that concept. But even with other vendors that aren't set up that way, what you're doing is essentially identifying cases for review. And that is a wonderful way to use those other systems.
Got it. Thank you. So Maria, you ask a question. It's good to see you here, by the way. Do you recommend the majority of our team members be a contributor? I definitely recommend that they be a contributor. A viewer doesn't really allow them to do anything. I would encourage you to put most people in as a contributor. All of you who I think are here were set up as administrators so that you can make changes to yours. Dustin, you asked about the PowerPoints. Our intention is to put the PowerPoints from all the PowerPoints from this presentation up on SimpleQI. They will be up in the resource center here on the main page. And let's see here. And Cherie added how to enter data by different agency location and SimpleQI. Cherie gave us a link there. Daniel, you said your baseline data is coming from one vendor and you'll be switching EPCR vendors. That is a common sport and a common challenge. And just like Jeff said, you just gotta pay attention to the details around it. And and you've done this long enough, and many of us on this call have done this long enough, where you can just kind of look at a couple of different data sets and go, wait a minute, this isn't right, something isn't right, and you're gonna work to figure it out and make it clear, and just going back and forth. Joe asked the question, how much baseline data do we want? And did we, Cherie, did we come up with a specific amount? I know I have my dream, but
Your dream was what we specified.
got it. So we'd like to get from the beginning of January 2023 to current. That will give us enough data points to download the data out of Simple QI and build valid statistical process control charts, which would be great.
So I don't know if I have all of these measures, but I have a lot of data from January 2023 forward. Would I load those by month?
Yes.
So my first data point would be January 2023, then again followed in February, March, April, all the way up through, let's call it October of 2024, giving us roughly 24 data points by the end of this year.
Exactly. Yeah, so when you come in
Perfect.
here, you just put in the month and date for your first one and information there. And if you've got it all on a spreadsheet, watch the little video and it'll show you how to do it on the spreadsheet.
Hey, Mike,
Yes.
this is Jeff again. Did we have, I remember a discussion a while back early on that for a lot of agencies, the N on Airway 01 is going to be really small. And there was a question about what interval to report on, you know, month versus year or something like that. Did we ever resolve that?
We decided we're going to ask for it monthly from everybody, I think is what we came up with.
Okay, thank you.
Yep. All right. I am there's a question in there about who should we contact if you didn't get something from Simple QI. You can definitely contact Cherie. I am going to put my my contact information in the chat. It's my cell number and my email. Between Cherie and Jason and I will be your tech support and administrators for Simple QI stuff. And the nice thing about Simple QI is that the two developers have become very good friend of ours. So if something breaks or doesn't work or whatever, we reach out to them and they're remarkably responsive about taking care of things. And with my cell phone number, texting works really well. Answering the phone, I suck at answering the phone. So you're welcome to send me text any time of the day or night. If I'm asleep, it won't wake me up. If you want to send me pictures of your pets, you're welcome to do that. I like all that stuff. So what other questions do folks have about any of this part of it?
Mike, for the agencies with very large numbers, going back to January 2023 may take some time. Just calculating it here, we're looking at about 1,300 cases. If we're gonna have to do manual review, that's gonna take some time. What kind of timeline are we looking at to get the baseline stuff in?
You know, we don't have a specific timeline in mind and are definitely empathic to the challenges of large amounts of data. And you know, certainly, you know, FirstWatch is willing to help you with as much of the lift as we can. But if you can, you know, if we could get it up by the end of this year, it would be fabulous.
Yeah, we can get all of them up. The only stumbling block is going to be the Airway 01. So we're working with people at FirstWatch, and hopefully we can get that data pulled.
That sounds great.
Yeah, hopefully those people at FirstWatch get their act together. I'm kidding, Mike.
We're working on it. Don't worry.
I know. I just was like, those people at FirstWatch.
Exactly.
I like it if we only knew someone there.
I know, right?
Any questions? Let's see. Joe said, sorry, I think the question was asked and I missed the answer.
Yeah, I'm
Whenever-
gonna work on, once I end this call, I'm gonna work on packaging those documents that I just received from Kelly Burleson, our measure development specialist, so that we can get them posted on the website tonight. And so part of the reason why we make everyone, even if you're not a member, just at least create a profile is so that we can communicate out when we make these changes. So there will be a mass communication that goes out to our database of anyone who has access to the measure technical documents, letting them know. So you all should receive that, barring any firewall blocking more emails from smurphy@nemsqua.org.
Right? That sounds good. We'll continue to pop your questions into the chat, and I think we will invite Brooke and Michael back up to bring us home for the end of this session. Thank you all.
Yeah, I just want to say really fast, thank you so much to Cherie Murphy. She is like the operation behind the operation. So I would really appreciate all her help in bringing all this together. And Jason too. Thanks, guys. Thank you everyone for participating. I'm really excited to work with you. My agency's in this collaborative too. So I look forward to learning from everyone. And I think Michael might have had to go.
All right.
And
Well,
Mike, I will pull up the homework
slide.
the homework slide. So our next steps, and as Mike was saying when he was demoing the simple QI, there's the steps for your team and there's the steps for the collaborative overall. So for your team, with all the great resources and discussion that is already being added to simple QI, we added the project lead that was on the application to simple QI. A few stragglers have been added. If somebody may have reached out to me via email and said, hey, can I get added? I may have done the favor of adding that person for you. But if you are the project lead in the application, or you think you should be, make sure that you check for that and add your team members. All you have to do is put in their email. That's it. And select their role, which Mike talked about. So it's very easy to add your team members. Obviously, if you need an assist, please reach out to me. We had great discussion on baseline data, work on getting that baseline data, and work on getting it entered into simple QI. If you're a system or group of agencies and you'd like to group your data by different agency or different locations or regions, whatever the case may be, check out that document and please reach out if you have any questions. When I was creating that document, I think if you start entering data before you input those series, as they're called, or groups in, it's not going to let you do it. So make sure that if you want to do it that way, that we set it up that way, and just reach out for help. I used to manage the Get With the Guidelines registry or database for AHA, so very comfortable with navigating these online solutions. So please just reach out. Don't struggle and get frustrated trying to set it up. Please just let us know. Also, if you have a table, I know there were a couple folks who were like, here's my data. That's great. Thanks for sharing it. You can, I'm happy to help you upload that data. There is a video, if when you're logged in, there is like a little question mark box in the top right that has some other general how-to resources. They're mostly videos. There's a video in there on how to import, I shouldn't say upload, it's import your data, which is basically if you have 3 columns for month, numerator, denominator, and you basically are pasting it into a table, it will import that data into your into your charts or your data. I'm not sure yet. I'll have to do a little more investigation how that works if you're doing multiple groups or have the series set up. I'm not 100% sure how that functionality will work there. So we may need to work on that if you have like a table of data and want to try and be a little bit more efficient. So do check out that little question mark box and see if that's something that will help you. And then I just have explore simple QI. I know some of you have already gotten in there and started some groups. We've got groups for different vendors already started, so keep that up. Check out the resources. I know we have a long list of resources to post on Simple QI, but you can also post your resources directly on there. We're happy to assist, but don't let us be the bottleneck. Please go ahead and share your resources with the group. After today's presentations, identify what your first change strategy and plan your PDSA, and make sure you enter it into Simple QI, as Mike pointed out. The reason for that is you've all generated some, commonality groups. We all use this vendor. We can start to create some support groups around, we're all working on this particular change idea. And so we can connect you together to get support from each other, as well as from our faculty on that change strategy or PDSA that you're doing. So while it may seem administrative, it really is so that we can help coordinate and get you the support you need. So don't forget to do that part, which is enter that first PDSA in there. And then plan and conduct your PDSAs and make sure that you're updating that PDSA document with your results. It's not a novel, it's not a book, it's just, quick short synopsis. And I think it will be also really beneficial, almost like journaling, to see this journey and remember what you've done over the course of the collaborative, because I often forget what I did last week. And then I find something and I'm surprised at the great work that I've done that I forgot about. And then I'm sorry that we didn't have the link, but we will send it out. Just sort of save the date, time for the office hours next week, the 24th at 3 Central, where we'll be able to continue that conversation on the nitty-gritty of how am I finding these patients? Can I do this? What do I do with patients in this situation? We'll have our measure development specialist, Kelly Burleson, on. We'll have Jeff and his team who does his manual measure review on, and then obviously all of you on to be able to share how you do things. So, and Mike, feel free before I go on to what you can do for the collaborative, if I have missed anything in my live note taking on what our next steps are. Is there anything I missed?
I think you've done a marvelous job, and I just before we end here at any point in time, I just wanted to thank all of you for signing up to make our world a better place. I'm at an age where I am more likely to need airway support than I am to provide it. So knowing that I can travel across this country and land in any of your spots and be well cared for provides me with great comfort.
Yes, I would echo that. And then there was a comment in the chat, which I thought was a great one, about sharing your checklist. So for those of you who do have a checklist that you use, I know there were, Jeff shared his, Wade, I think, shared theirs in their presentation, but if you have a checklist, we can certainly start maybe a folder in Simple QI for putting checklists in there. And then Jeff also added in the comment, somebody had asked, and they've actually been Steve Cohen may have asked about the spreadsheet or whatever Jeff and his team uses to review airways. And so one of our dreams is to, at least with this collaborative, because I forget the exact percentage, but I think it was a little over 50% of the participants in this collaborative do some sort of airway registry. So if you could share your airway registry data collection, what we'd like to be able to do is at least identify a common set of elements for an airway registry. The next step from that, we'd love to be able to have an airway registry, but at least the first step being to identify that common set of elements. So if you for the good of the collaborative and national airway improvement would be willing to share those things, you can either put them in Simple QI, or if it's easier, just send a direct message to me. That would be great. That is it from me as far as sort of the homework next steps. Mike and Brooke gave us our motivational closeout. So I think we can go ahead and just say, thank you all. We're looking forward to this improvement journey with you, and please let us know if you need anything.
Yes, and Elizabeth, everybody was added as an administrator for the first round to answer your question.
Have a good one, guys.
Thanks,
Thanks,
everyone.
everybody. Looking forward to it. Bye-bye.
All right. Thank you.
Thank you.
Hey, Mike, are you host? Can you stop recording, or?
I think I can.